Hello again, and we are dealing today with a acute exacerbation of COPD, which is one of the most common cases that came in for a hospital admission under the acute meds. Again, the most important thing where we are clerking the patient, we take the name, the hospital number, the date of birth, the patient details on the sticker. You can find it there. Put the date, the time, and your name, and who you are, what's your grade, and put the patient age. And the present complaint here would be what? Shortness of breath and cough for the last 2 or 3 days. And then you should again write everything about the present complaint. So something like, gentleman, let's say a 65 years old gentleman presented with shortness of breath and the cough of green phlegm for the last 3 days, which is getting worse, and the shortness of breath is getting worse as well, mainly on exercise or on walking, and he had some fever at home as well, but he did not cough any blood out and he did not lose any weight. There is no night sweats. So you are trying to rule out some other stuff like a PE or a cancer while you are putting the present complaint for the patient. And then mention the other stuff. What the other stuff are. So the patient has no chest pain. The patient has no left side chest pain. So you are saying that there is no myocardial infarction there or a problem like heart attack in the situation. And then continue. So as we discussed the last time, we need to find about the frailty situation of the patient. So the patient live with his wife in a house, and he cannot go upstairs. The and the toilet is upstairs. That does mean that the patient has moderate morbidity or moderate frailty. He needs some help at home because he cannot do some washing, he cannot do some shopping. So you will need to put the patient frailty score. Why? Again, like the last time, will the patient require ITU admission? So I should consider that. Will the patient will be on ward level care, or he will be for non-invasive ventilation, so he will be at HDU. So you need to find out the frailty score of the patient, and then mention some other stuff about what is the past medical history. So you know the patient has like a COPD, diabetes, hypertension, whatever the patient have, put it in the Boston medical history, and then quickly do some review for the other systems, as you mentioned in the clinical, in the present complaint there, shortness of breath, the cough, the sputum, the hemoptysis, whatever the patient have. The drug history, the patient must be, if he come in with shortness of breath and the COPD, so the patient must be on inhaler, so the patient is on Trembo, on salbutamol. Is he taking long term of steroids or long term of antibiotics, right? And if he is on long term oxygen therapy as well. Is the patient allergic? The patient most of the time having smoking history, so he smoke around 20 pack a year or 30 pack a year or 100 pack a year. The alcohol, what he drink, and so on. So vital signs, the most important bit, we need to write it clearly while we are dealing with patients coming with shortness of breath. What is the respiratory rate? What is his oxygen saturation? Is it more than 94? Is it between 88 to 92 on a scale 2? What is the patient oxygen saturation when he came in? Right? And we'll discuss why now. What is the patient temperature? What is the patient news score? Are you with me? Yeah,
Yeah, with you.
yeah. I'm talking too fast. I'm sorry about that. Why we need to do
No
that?
problem.
Why? No, good. So why we need to take the vital signs for this patient? Do you remember?
Yeah, what?
Do you remember this picture?
Yeah,
What's that?
sepsis protocol.
Sepsis pathway. Yes, sepsis pathway. So, because if there is a red flag, if there is a red flag, it does mean that we should consider sepsis pathway. And in sepsis pathway, as we discussed the last time, you will need to give the patient oxygen, give the patient fluid, give the patient antibiotic. And you need to take some, before giving the antibiotic, you need to take the blood, and you need to take blood culture, and you need to do ABG or VBG. Yes? Yep.
Yes.
And you need to put a catheter in to see the urine output. Do you remember the sepsis pathway?
Yeah.
Do not ever forget sepsis pathway. Not ever, ever forget sepsis pathway. All right?
Nice.
So after you take the, to make sure that the patient is septic or not, so quick examination within 2 to 3 minutes to see about everything, the chest, peak flow, if the patient can do, of course, and there's no need for neurological here. And if the patient has chest X-ray, just document the finding. If he didn't have it, please request it. ECG, ask the nurse, I need ECG for this patient, please. Okay, because you need to make sure that the patient hasn't have acute heart attack. All right, or ischemic
Nice.
heart changes. All right. Before heading to the plan, let's discuss the case again. So the patient, 65 years old, he came into you with acute exacerbation of COPD. He came in, and you know that the patient is heavily smoker, and he cannot stop smoking because they never stop smoking, and he is coughing greenish phlegm out. All right.
Mm.
The first step to do with this patient from the management plan is the investigation first. All right. So investigation, what investigation you need to do for this patient when he came in? The first thing, to put a cannula in, to take some blood and send it quickly to the lab, and this blood will contain the full blood count, urea electrolytes, liver function test, CRP. All right. And you need to send some blood culture, please, and send some sputum culture, please, and request a chest X-ray and the ECG, and do ABG. Any patient came into you or is in the ward with shortness of breath, you will need to do ABG. Yep,
Yeah.
you need to do
APG.
ABG. You need to know how to read ABG. Okay, we will jump to the ABG in a minute, and I will quickly tell you what to look at. All right.
Yeah.
Good. So this is the clerking sheet. Okay. What is the first thing? Again, you will do the to the patient while you are asking and doing the bloods and all of this stuff. Ask the nurse, please, I need back-to-back nebulizers for this patient. You need to give salbutamol back-to-back. And salbutamol 5 milligram because he is 65 years old, 5 milligram back-to-back. You need to give ipratropium bromide back to back again to the patient, back to back. Why? Because the patient has COPD, yes?
Yeah. Yeah.
And if you didn't open the airways, the patient will arrest, will have respiratory arrest. So you will need to give quickly. Give a salbutamol now. Give ipratropium now. Give him steroid now. The
Mm.
steroid dose, which is 30 milligram, right? Give 30 milligram oral cortisone now, right? Okay.
Okay.
If the patient oxygen saturation less than 88, less than 88, give oxygen. Give oxygen to reach 88 to 92, which is a scale 2. We cannot put the patient in acute exacerbation on a scale 1. Do you know why? Scale 1, which is more than 92, which is more than 94, exactly.
Mm.
Because we don't want hyperoxygenation for this patient. All right.
Okay. Yeah.
Okay. So make sure that the patient with type 2 respiratory failure or acute exacerbation of COPD and coming to you in the hospital, he is on a scale 2. He is on a scale 2.
Two.
All right.
Yeah.
Okay. Good. All right. Fair enough. So if the patient, so the patient, now you put him on salbutamol, you put him on ipratropium, you put him on steroids, you give him some antibiotics, right? And the EBG came back to you. And when the EBG came back to you, you had a look at it. You had a look at the EBG. What is EBG? You had a look at the EBG, right? And when you had a look at this EBG, what is the first thing you should look at? The BH, yeah?
Yep.
So the normal BH is from 7.35 to 7.45. You need to make sure that the patient pH is not at the acidotic level, is not at the less than 7.35. So if the patient has the his pH 7.25, it does mean that the patient had acidosis. Yeah,
Yep.
good. Then have a look at the PO2. The PO2. The PO2, uh, if it is on the lower side, it does mean the patient had respiratory failure. Yeah,
Okay.
good. So I will not read anything at the moment. So we need to just put something in place just to remember. Let's try to write something here. So if the patient came in with acute exacerbation of COPD, you need to know, is the patient on type, which type of respiratory failure it is. Yeah, is
Okay.
it type 1 or is it type 2? Okay,
I can't see anything.
you cannot see it. It is on mirror. I will share this screen instead. Continue. Can you see this one now?
No.
No worries.
Yeah. I can see it
Type
now.
2. Good. So is it type 1 or type 2? So let's say that, or let's make sure that we are not missing with it. So type 1 and type 2. So type 1, PO2 will be BO2 first, will be normal or higher. B2 will be low. Yeah.
Yeah.
And in type 2 respiratory failure, BO2 will be high or low.
Low.
Okay. And in type 1 respiratory failure, the BCO2 will be higher or lower.
Lower. I think that.
Okay. And for the BCO2, will be in the high or the lower.
Higher.
Okay. So let's jump more. What about the BH? BH in type 1 will be normal,
Mm,
right?
okay.
BH in type 2 will be,
Higher.
again,
Lower.
no,
Lower.
acidotic.
Yeah. 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 Okay. Yeah.
Usually acidotic.
Yeah.
Usually acidotic. Okay,
Yeah.
that's fantastic. All right. So this is easily we're talking about the type 1 or type 2 respiratory failure.
Mm,
For us, for today case, we're talking about infective exacerbation of COPD. Right? So usually we're talking about type 2 respiratory failure. Right? Usually we're talking about type 2 respiratory failure, right?
yeah. Yeah.
Which is the pH is low, BO2 is low, and the BCO2 usually will be higher, all right, on the higher level.
Right.
Okay,
Okay.
that's fantastic. Good. So you give the patient, you did the ABG, and the ABG came back, and you did see that the patient had type 2 respiratory failure, and you started to give him everything. You started to give him salbutamol, and you give him the ipratropium, and you give him the steroids, and you give him the antibiotics, which is according to your guidelines would be something like comoxiclav or or whatever, tazocin, and you asked the nurses to do the news score to see the patient oxygen saturation, and we did find the oxygen saturation for this gentleman is 92, and he is getting better right now, and so you will consider stop oxygen for this patient, and you will admit the patient to the ward, right? Okay.
Okay.
You have another problem now. The pH, you did repeat the ABG again after 1 hour from the patient, after 30 minutes, not 1 hour, after 30 minutes from the patient came in, and you did repeat the ABG, and the gentleman is not getting any better, and you find that the pH is 7.1.
Mm.
Okay, and you
Yeah.
did find the let's say the BO2 is let's say 6, and you did find the BCO2, let's say 9, right? So it is low, low, high. So which type of failure it is?
Type 2.
Type 2 respiratory failure. Okay, and it is less than 7.2.
Mm.
Okay,
Yes, yes, yeah.
and the patient is not responding, and the patient deteriorating. Okay,
Yeah.
so it does mean that you need to call I ITU or ICU. Why? You need to put the patient on BiPAP. Okay,
Okay.
you need to put the patient on BiPAP. If you didn't, the patient will get in a respiratory
Um,
failure. Right?
uh,
Okay. All
yes.
right. Okay. So I'll stop here,
Yeah.
and I'll go back to the clerking sheet, because we are talking about the clerking stuff here. I'll share this with you. So what we need to do now is to mention about the plan. So you are admitting the patient, and the patient was in the ITU, was in the A&E, and you need to admit the patient now. So what is the plan? So the patient is stable, and you will send him upstairs to the ward. What is the plan? What should you write in the plan? All right. So as we again the same last time we mentioned that to do the plan you need to write clearly what you will do and what you did. So first of all, you did FBC, you did bloods, including FBC, use and ease. Can you see the screen?
Yeah.
LFT, you did blood culture, and you did sputum culture, right? And you did chest X-ray, isn't it? Chest X-ray, all
Yeah.
right? And you did ECG, okay?
Yes.
And the EBG, you did EBG, and repeat, you did EBG, was arterial blood gas, and repeat EBG again, all right? After 1 hour, and you attached the slips with it, the EBG result, you just attached it to your paper, or it is on the system already, okay? And you mentioned that to give the patient. What did you give the patient? Back to back nips. Yeah, you
Yes.
did that. Yes,
Yeah.
you give the patient steroids. Yeah, and you give the patient some fluids as well. Yeah,
No.
which is, let's say, normal saline. Normal saline. All right.
Yeah. Yeah.
You give him, how much did you give him? You give him 500 mils. Let's say 500 mils. All right.
Yeah.
What antibiotic? Whatever the antibiotic according to your guidelines, you give him whatever the antibiotic according to the guidelines: amoxicillin, doxycycline, clarithromycin, coamoxiclavan, clary, whatever you
Mm.
give. All right. And what is the escalation plan for this patient? So some patients have came into you with DNA CPR in place, do not resuscitate.
Mm.
Some patient came in with ward ward level ward based care. Okay, so you will he is not for sorry, not for BiPAP. Okay,
Yeah.
some patient came in and he is for full escalation, for full escalation for everything. All right, and he will need ITU discussion. So after you stabilize the patient, or you give, or you did some stuff to the patient, and you find that the patient is not deteriorating, is deteriorating, and he is full for escalation. So um, you will need to speak with the ITU team because the
Mm.
patient is deteriorating. All right.
All right. Yes.
Okay. So after all of that, that's why if you remember the frailty score, that's why every single patient came into you, you admit him, you will need to do the frailty score, right?
Mm.
No, you should know where is the patient is. Is the patient is full for escalation? Is he mild frail? Is he moderate frail? Is he severe frail? It is easy like that, you know.
Yeah.
It is easy like that. There is no much you need to know on how to deal with it. So it's 1, 2, 3, 4 steps. If you need how to do these steps, it's easy like that.
Mm.
Do it like that. Patient came in with shortness of breath directly. Do some bloods, put some fluids, take the ABG. Any patient can watch shortness of breath, take ABG, do the news score. Is it a sepsis screen? Give salbutamol, give ipratropium, and give some fluids, and send him for chest X-ray. Have a look at the ECG. Get him admitted. If repeat the ABG. If it is not responding and it is deteriorating, just ask for some help from the ITU team. Please come over. We will need to put this patient on
Mm.
BiPAP. Right?
All right.
Okay. So regarding, I'll go back to. I told you I'll give you something about the ABG and what else? BiPAP. Yeah.
Yeah. Yes.
Let me share uh, this screen with you. I'll put a video. Uh, So this one is really easy one. This about the EBG. Okay, it's very nice and smooth and the tiny video.
Acidosis. Looking at our PaCO2, our normal is 35 to
There's no
45.
video.
So
Come again?
Yeah. I can see it now.
this is normal. Looking at 45. Look at these numbers. But if you do memorize these numbers, trust me on this. Interpreting ABGs will be a breeze for you guys. Now, let us talk about the actual 3-step ABG interpretation. And these are: identify if it is acidosis or alkalosis by looking at your pH. Identify if it is respiratory or metabolic by looking at your carbon dioxide and bicarbonate. And number 3 would be identify if it is compensated or uncompensated. First step is identifying whether it is acidosis or alkalosis. Again, our normal value for our pH is 7.35 to 7.45. If your pH is less than 7.35, you have acidosis. If it is greater than 7.45, you have alkalosis. Let's see some examples. For a pH of 7.25, it's less than 7.35, so you have acidosis. Another example. pH of 7.55 is greater than 7.45. So what do you have? You have alkalosis. Step number 2, would be identifying if it is respiratory or metabolic. And we're going to do this by simply looking at your bicarbonate and carbon dioxide and compare that to your pH. Through this, we will know whether you have respiratory or metabolic condition. And the method that we are going to be using will be the concept method. Now, the most common method being taught in nursing school is what we call the row method, where they ask you to use arrows in interpreting your ABGs. However, we will not be using this here because the row method doesn't really work well for compensated ABG. So for now, we are just sticking with the concept method. So what is the concept method? We talked about this earlier already, and that is carbon dioxide is being regulated by your lungs while the bicarbonate is being regulated by your kidneys. If your carbon dioxide level is abnormal while this bicarbonate is normal, you have a respiratory condition. On the other hand, if your carbon dioxide is normal while this is abnormal, you have a metabolic condition. And just to throw it out there, remember that carbon dioxide is to acid while bicarbonate is to base. It is best if we use examples for this method. 7.25, PaCO2 of 50, and bicarbonate of 24. Looking at the pH, we can tell that this is acidosis. Our normal is 7.35 to 7.45. It's less than 35, so it is acidosis. Look at the PaCO2. It's elevated. Our normal value is 35 to 45. We have 50. Just by simply looking at that, this is abnormal, and if you look at the bicarbonate, it is normal. Our normal value is 22 to 26. So this is normal, this is abnormal. What do we have? We have a respiratory condition. Therefore, we have respiratory acidosis. And just by simply looking at the PaCO2, 50, that means you went beyond 45. If you have more CO2, your blood is more acidic. So respiratory acidosis makes sense here. And of course, your bicarbonate, it's normal. Another example, pH of 7.56, PaCO2 of 28, and bicarbonate of 22. The pH, what does this tell us? Is it acidosis or alkalosis? It's alkalosis. It's more than 45. Looking at the PaCO2, our normal is 35 to 45. It's less than 35 to 45. Look at our bicarbonate. Is this normal? 22 to 26? It's normal. So since your PaCO2 is abnormal, we have a respiratory condition. Therefore, it's respiratory alkalosis. And if you look at the PaCO2, we don't have enough acid in our blood. That means it's making our blood more basic. So respiratory alkalosis will make sense. And of course, our bicarbonate is normal. What about this? 7.25, PaCO2 of 37, and bicarbonate of 21. Looking at our pH, is this acidosis or alkalosis? It is acidosis. Looking at our PaCO2, our normal is 35 to 45. So this is normal. Looking at our bicarbonate, our normal is 22 to 26. Since our abnormal is the bicarbonate and the CO2 is normal, do we have a metabolic or a respiratory? We have a metabolic condition. And since this is acidosis, we have metabolic acidosis. Think about this for a second. Our normal is 22 to 26. We don't have enough base in our blood. That means our blood is more on the acidic side. So metabolic acidosis does make sense. Another example, 7.56. We have 44 carbon dioxide and bicarbonate of 35. Looking at the pH, we have alkalosis. Our PaCO2, it's normal. Our normal is 35 to 45. And our bicarbonate is 35. Since our abnormal is bicarbonate and the CO2 is normal, we have a metabolic condition, and we relate that with our pH. We have a metabolic alkalosis, and this makes sense because the more bicarbonate you have, the more basic your blood is. Now, you guys might be wondering, what if your PaCO2 is abnormal and your bicarbonate is abnormal? Or what if your pH is normal and both of them are abnormal? You have to remember that the examples that we just used just now, these are examples of uncompensated ABGs. If your pH becomes normal and both of them are abnormal, we have compensation going on. We're going to talk about that in step number 3, which is identifying whether it is compensated or uncompensated. My twin brother Ben.
Again, this video, you'll find it attached in the drive, so I will not waste his time in putting it here. but you can have a look on it from the clinical drive. I'll show you something else now about the BiPAP itself. What is a BiPAP and how we are dealing with it? Can you see this video?
Yeah, I see.
Yeah. So this one is the PIBAB, which is again the machine for non-invasive ventilation. We will listen to 5 minutes here to see what is it and how you deal with it, because sometimes you might need to do it yourself. Please, you will find this video as well. I'll put it now in the drive,
Okay.
but please listen carefully.
Patients that don't have their own that bring in or that are acute, maybe start in the ER with a CHF, respiratory failure, COPD exacerbation. We're going to want to set them up on our machines anyway because it's a little more intense for the patient, works a little bit better. We can set our FiO2s a lot easier on those. So we have two BiPAPs that we normally use. We have our BiPAP Vision and our V60s. We're going to start with the BiPAP Vision. We'll go over the settings. Then I'll show you how we do some changes, and then we'll go over the V60 in the same way. We use the same mask for both machines. We have nasal masks and we have full face masks. These are our full face masks. As you can see, it has a head adapter. Our clips come around. We have our tubing that goes to the machine. This is for the flow and the oxygen. This little line is our pressure line. If this little line comes off, the machine will alarm and it will not function. So if it starts to alarm, just make sure that these lines are on. This is our exhalation port. This is a Castle port. This has to be open. If you occlude it, the patient doesn't have the ability to exhale. So it's kind of important that we leave that open. Tubing goes to the machine, runs from a filter. This makes sure that anything that's in the air doesn't go to the patient. When they exhale back through, it also will trap any particles and that type of thing, humidity and whatever. The mask itself, we size to the patient's face. So for a full mask, we want to size from the top of the bridge of the nose to just below the bottom lip. This patient is probably a small, which is what I have. It lists on the mask itself what size it is. So this is a small. We also have medium and large. When you first place it on the patient, you want to make sure that you cover both spots. Again, bridge of the nose, bottom of the lip. If the mask is too big and it goes below their chin, then it's going to cause a huge leak. We want to make sure that it fits there. Our straps go behind the patient's head. This is where it's helpful to have an extra set of hands. The clips come around. These ones click right on. And then we can adjust it with the Velcro straps for patient comfort. Now when we adjust, we want to make sure that we make it just tight enough that we don't get a big leak, and we don't want it to be too tight where it covers up or causes pressure on the patient's face. Now because our patient here has an exceptionally small head, this normally would fit a little tighter, but he doesn't have that ability because his head is so small. This little part can also adjust for patient comfort, so we can tip it out or tip it in. The main goal is to make sure that we don't have a big leak. A small leak is okay as long as the patient's oxygen levels are staying good and the pressures aren't alarming too much. So once we set it up, we usually feel around the face for any air leaks. If there is one, we'll adjust. This is the only spot, again, that you should have air coming out, so make sure that that's open. I like to keep it so it's facing out. If it's turned towards the patient, it becomes annoying to them, so just make sure that it's pointing up. Once it's all set, make sure that your machine is functioning. You'll hear it cycle. Then we'll go to our settings. Okay. So as I said, BiPAP is 2 pressures. We have an inspiratory pressure and an expiratory pressure that we set. Both are ordered by the physician as well as the FiO2, the oxygen content. So normal starting range is an IPAP of 8 and EPAP of 4. For patients that need extra oxygenation, we can increase the EPAP, which is like PEEP. For patients that have extra CO2, wait, no, that's not what I want to say. For patients that have increased CO2 levels, we want a higher IPAP. We want to blow off that CO2. So right now you can see we have our IPAP set at 8 and our EPAP set at 4. We have a rate that we set, and he's reading 14 right now. When I go to my parameters screen, my rate is set at 10. So I know he's doing 4 spontaneous breaths on his own. Our oxygen level right now is set at 40%. We can change that anywhere from 21 to 100%. It's very precise. So if I definitely want this patient on 40%, I set it at 40%, and that's what they're going to get. With the home units, we bleed in the oxygen at liters per minute, so it's a little more variable. That's why we like to use these for the acute patients. Our monitoring screen looks a little bit different than our parameters screen. Parameters is where we set things. Monitoring is what is normally displayed when you're looking at it. So again, IPAP 8, EPAP 4. His total rate is 13. Down here we have a tidal volume. Tidal volume is attained by the difference in pressures between the IPAP and the EPAP. So if we widen that pressure range, then we'll theoretically have a larger tidal volume. So essentially this is a non-invasive ventilator. We can actually ventilate patients to a certain degree with the BiPAP. Our minute ventilation is displayed in liters per minute. Our PIP, which is the positive inspiratory pressure, the peak inspiratory pressure, should be right around our IPAP. When it gets to that PIP of 8, it comes back down. Our pressure line shows us each breath. Our inspiratory pressure should hit to the 8, expiratory pressure should come back down to 4. Volume, you can see each breath, how big of a volume the patient is taking, which is right around the 250 mark. And then our flow, as flow is disrupted, you get the little blip. So you know everything is functioning correctly there. Modes, we can change this to a standard CPAP. We don't normally because most patients need the BiPAP, but it is a possibility to do, and respiratory would make those adjustments simply by pressing the button, activating, setting our CPAP. We have alarms set. Our alarms are set with a high pressure of 50, so if the patient coughs,
you should know how to do ABG, because it is the main thing you need all the way when the patient came in. So 1 hour so when the patient came in, then 30 minutes, then hourly. And if you are doing it on a BiPAP, so till the patient is stable, and then you can do it after 4 to 6 hours, or if the patient deteriorate.
Can you straighten your arm for me, please?
So ABGs, arterial blood gas, you know how
Extend your wrist.
to take the blood from the artery. Simple technique, but you need to learn it. And you need to get familiarized and to familiar yourself as well with the BiPAP. Because it's really painful. You need to give some local anesthesia, but to be honest, from the clinical point of view, we don't do this normally. Usually we take the blood directly from the artery, because again, there's no time to do all of that. So the heparinized needle syringe, we just put it, and then you will see the pinky, lovely blood coming out from the artery. It's pinky, it's really pinky. Okay, and do not do any aspiration. And good compression, very good compression after you finish for at least 1 to 2 minutes, and ask the patient to keep the pressure on. Right, so we're done. That's everything today. All right, so this about acute exacerbation of the COPD. Hopefully, you know what to do when you see a patient with severe shortness of breath with exacerbation of COPD. You will find the guidelines there, and the antibiotic will find it there. You will find the EBG and the EBG video and PIPAP video as well. You'll find it in the on the drive. Enjoy it, do it quickly, and do it right. All right.
Okay.
Thank you very much. I'll see you in the next video.
Okay. Okay. Bye.
Let-